You indicated that you would expect 25 milligrams of propofol in a person 61.7 kilograms would last about somewhere between 6 and 10 minutes, correct?
That's right.
And after that, you would not expect there to be sedation, would you?
In a patient that is not on other medications, does not have other medications in their system.
Right.
Traditionally, yes, I would not expect them to have residual effects.
And would you expect that patient to automatically wake up as soon as the propofol sedation effects were over?
I would expect them to gradually have increased level of consciousness.
Okay, would you, I mean, at the 10-minute mark, would you expect him to automatically open his eyes and get up?
I think every patient is different.
Okay, so it wouldn't be unusual for the patient to continue to sleep after sedation like that, would it?
Are you just referring to someone that just got propofol in and of itself?
Yes.
No, I would expect that patient to wake up.
Okay, and if the patient were tired, would it be unusual to see that patient continue to sleep?
In the capacity that I use propofol, in my line of work, absolutely. I would expect them always to be awake if I was using propofol as I use propofol on a daily basis. I would not expect them to be asleep afterwards. That would be actually very troubling.
In the event that they were tired and been trying to go to sleep for 9 hours or 10 hours, and they were extremely tired, would you expect them to continue to sleep?
I think if I was using a drug for sedation, it is my obligation to assess whether that is sleep or the effects of sedation. So, this is really imperative on the physician. If I'm sedating someone and they stay asleep, I have to make sure that it's not the effect of the sedative. So that is the responsibility of the physician caring for the patient.
So you think
to make that determination.
You think once you've sedated a patient's gone to sleep, you should then wake them up?
If somebody's gone to sleep, and if I've been sedating the patient with propofol, I would want to assess, yes, I want to assess if they are responsive to external stimuli. Absolutely. I have that obligation. I want to know if it's the effect of the drug or if it is them being asleep. If I was using that drug, that is my responsibility, absolutely.
But when we're talking about using this, what we previously described, a minor amount, you don't think you can rely upon that being either metabolized or redistributed after 10 minutes?
I think the amount is not important. If you are bold enough to have the lack of judgment to use propofol in this setting, it is incumbent on you to make sure that it's not the effect of propofol and to keep monitoring the patient.
Well, would you feel confident after 20 minutes that propofol was not the agent keeping the individual asleep?
I don't think time is a factor. I would make a continuous assessment to really figure out what is the underlying cause of the patient's diminished level of consciousness. And if I had been using a sedative, I want to first know if it's the sedative that is doing it.
So it's your testimony that in evaluating the effects of propofol, time is not a factor.
That's not what I'm saying. I'm saying if I am using propofol as a sedative and I have a patient that you're describing that I think the propofol should have worn off and they're still not responsive, it is my duty to figure out what is going on. Could it have been that this was some effect of other additive effect of propofol in addition to other medications? Could there be something going on? It is my duty to figure that out. And I think that is something we always practice in medicine. We don't really just make judgments, well, a little bit of this is okay. If that is a medication that requires continuous monitoring and you're using it, you have to continue monitoring the patient. You can't make exceptions. And I think what you're alluding to is making an exception, saying, well, that drug should have worn off, it was a little dose. And what I'm saying is that patient should have been monitored, and there should have been assessment made as to whether that could have been the effect of the sedation.
If the patient continued to sleep for an hour, would you be confident that there was no propofol
Well,
causing the patient to sleep at that time?
sleep is different. I would say, as an answer to that, I would continue monitoring the patient vigilantly and making sure. I would want to make sure if that is sleep or if this is a depressed state of consciousness induced by a combination of medications.
Okay. As you monitor that patient visually, do you think you can tell whether or not he is sleeping naturally or not?
Excuse me?
As you continue to monitor that patient visually, as you just described, will that enable you to tell whether or not that patient is sleeping naturally?
I think the most important thing is if you are using a drug like propofol, which I would never advocate, and we've discussed
You know,
that.
Your Honor, could you...
Well, I think calls for either a yes or no. So the objection is sustained, the last answer is stricken, disregard. You may re-ask your question. Listen carefully to the question.
Sure.
If you're able to answer it, yes or no, do so. If not, tell us. Mr. Flanagan.
Do you think by visually monitoring the patient that you could determine whether or not that patient was sleeping naturally or not?
No, that's a determination you can't make by just visually monitoring the patient, and you need to assess and you need to see if that person is responsive to external stimuli.
So just by watching his breathing, evaluating his pulse and his oxygen saturation, it's your testimony that you, and after the passage of significant time, whether it's 10 minutes, 15 minutes, or a half hour, it's your testimony that you would not be able to determine whether or not that patient was sleeping naturally.
I think that you're asking this question in the context of this case. And in the context of this case, Mr. Jackson had received other agents that could have had an additive effect. And in this situation, no, I wouldn't have. I would have continued to monitor, and I would have, if I had that question, I would have assessed whether the patient was responsive to external stimuli.
So you'd awaken him up.
I owed that to the patient if I felt like it could have been due to the medication. That is my primary responsibility, is the well-being of the patient.
And that would include a patient that you spent the last 9 hours trying to get to sleep.
My obligation is to the well-being of the patient, not what the patient necessarily perceived as what's important to them. If I feel that could do my patient more harm, if the potential of the sedative effects accumulating is more significant, absolutely I would do that.
And does the patient's ability to sleep have anything to do with his well-being?
I think that is an issue that is more a chronic issue, but we always have to prioritize in medicine. We have to deal with problems that could be more significant, and I would want to make sure that it was not something more significant here.
So when Dr. Murray stated that he gave him the IV and proceeded to watch him until he was comfortable with the fact that he was sleeping, you don't think Dr. Murray was capable of making that assessment?
No, I think that's a very difficult assessment to make in this circumstance.
Okay. Now, do you think propofol should ever be used for conscious sedation?
You mean moderate sedation, is that correct?
Conscious sedation.
Yeah, I mean, that is a term that's, now more often we use the term moderate sedation, where patients are still responsive to stimuli, to verbal stimuli. I think there is a role in a very highly monitored setting, absolutely.
Now, You referred to, on your report, you indicated that you determined that Mr. Jackson had, I think you used the term, massive doses of deep sedatives. What does massive doses mean?
I suspect that in addition to getting the 25 milligrams, he likely had a drip that was not being infused via a precise pump where there was a precise mechanism to regulate how much was going in his system.
So you think he had a drip?
I think if you read the notes from Dr. Mary's interview on page 62 with Detective Martinez, there is when he asked him about how he used propofol, he mentioned doing the push and then following it with a drip.
You're referring to the same paragraph that was referred to by Dr. Steinberg?
Objection calls for speculation.
I will rule the objection if you know.
I have no idea. I haven't listened to Dr. Steinberg's testimony.
That's the answer. Okay.